Invite the next speaker, Dr. Gunjan, a well-known oculoplastic surgeon of the Central India, to tell us more about the masquerades of orbit and oculoplasty. All over to you, Gunjan. Please stick to your timings, Gunjan.
Yes, sir. Maybe I'll start the timer myself. It's there?
It's there.
Okay. Good afternoon, everybody. My name is Dr. Gunjan RATHI, and my topic for today is masquerades in orbit and oculoplasty. At the outset, I would like to thank the Asia Pacific Society, All India Ophthalmic Society, and Vidarbha Ophthalmic Society to provide me with this opportunity. Now, what are the masquerades that we are discussing today? Let me explain this to you with the case of this 13-year-old female child, a syndromic child, who presented to me with a right eye upper lid mass. Now, the parents said that she had developed this mass in the last 15 days. It was slowly growing, painless, and when I examined her, it was a papillomatous fleshy pink mass which appeared to be arising from the palpebral conjunctiva of the right eye upper lid. She also had developed ptosis in the same duration, which appeared to be mechanical ptosis. Now, it appeared like a viral papilloma to me. I asked them to get a mass excision biopsy, so gave them blood tests and asked them to come back. Now, they came back in 15 days, and what I saw was this. The mass had increased so much in size that she was not able to open her eyes. She has also developed proptosis in the same duration. Now, a rapidly growing mass in a child cannot be a good sign. So I went ahead with MRI orbit, and what I saw was the mass had now extended into the orbit superiorly. With this, I went ahead, did a mass biopsy, sent it for histopathology, and it came out to be rhabdomyosarcoma. The patient was then sent to the pediatric oncologist, and she needed chemotherapy and radiotherapy for this. Post that, she has been doing well. Now, these are the cases that we are talking about today. Cases which actually appear to be benign, inflammatory, or infective in the beginning, but actually turn out to be more serious in the form of malignancies. These are the wolves which actually appear under the sheepskin. Now, what are we supposed to do when we deal with such cases? Early diagnosis. The earlier you diagnose them, the better it is for us so that we can treat them early. For the ease of understanding, I'm dividing the further part into lid and orbital cases. So coming to the lid pathologies, this gentleman is a 70-year-old man who came to me with a right eye upper lid mass since 6 months, again painless. He was actually referred to me by a colleague ophthalmologist who had done an INC, incision curettage, on him the previous day and said he could not remove it completely, so referred him to me. What I saw was a fractured tarsal plate with a lot of cheesy material on the conjunctival surface. But along with that, what I also saw was a nodular swelling at the lid margin. When I went back in history, asked for details, the patient then said that 3 years back, he has removed this mass, he has gotten it removed twice, and none of the times biopsy was done. So now we were looking at a recurrent mass in an elderly individual, which also was presenting with a lid margin nodule. This was definitely not a routine chalazion. So I went ahead with a wide margin excision biopsy in frozen section, did the lid reconstruction with the help of Tenzel flap, and sent the sample for histopathology. It came out to be sebaceous gland carcinoma. This is the patient's photo 3 days postoperatively. Oncologist opinion was sought, and because the mass was removed in toto, only observation was advised for him. Now, what could have been done in this case? Maybe if you have already done an incision curettage and you feel that it is unusual, you can send the sample for biopsy then and there, instead of waiting. Now, because chalazion is a common thing, let me just explain it to you a little bit, how to differentiate between them. So a typical chalazion generally is present in younger individuals with a round, cystic, well-defined swelling, generally limited to the extent of the tarsal plate. On eversion, what you see is just thinning of the conjunctiva with some pinkish gray discoloration. And sometimes a small granuloma may be present in case if it is a burst chalazion. Other than that, in case if you feel it is in an elderly individual, the mass is rounded, ill-defined, firm, it is going beyond the extent of the tarsal plate. On eversion, if you see that there's a lot of cheesy white material which is stuck on the inner surface, which is going even beyond the extent of the mass, or some papillomatous mass or some kind of mass which is growing from the conjunctiva. All these things are atypical, and all these things warrant biopsy. Coming to the orbital pathologies, this is a 33-year-old female who presented to me saying that her left eye appeared to be larger than the right eye. She was a known case of thyroid for 6 years, on medication, doing well. She was also consulting an ophthalmologist where lubricants were given to her, and she was told that her eyes might look bigger than normal because she might be having thyroid eye disease. But after looking at her, what I found unusual was she was having an inferior dystopia instead of an axial proptosis. Also, the other signs of thyroid were also absent. Because it appeared confusing, I went ahead with a contrast-enhanced CT scan, and what I saw was a mass pushing the eyeball down, lying between the roof of the orbit and the eyeball. Now I went ahead with superior orbitotomy with mass excision biopsy, sent it for histopathology, and it came out to be pleomorphic adenoma of the adnexal glands, which is actually something rare. And this is the patient 10 days post-operatively. Now again, oncologist opinion was taken, and because the mask was removed in toto, all she needed was observation. So how do we differentiate between an exophthalmos and proptosis because of other cases? An exophthalmos will be present generally as an axial proptosis with other signs of thyroid in the form of lid retraction, temporal flare, upper or lower scleral show, and also lid lag. These patients also generally have a lid, neck swelling, which might be absent in the other cases of proptosis due to other causes, and then you will be able to differentiate. With this, let me just reach the end. Let's recap whatever we have learned about the wolf that we were talking about. First, when in doubt, frequently follow up the patient. If you follow up the patient, keep on a close follow-up. In 2 or 3 sittings, you will understand if you feel that the case is atypical. These are the times when you actually need to manage them urgently. Second, O for oncologist opinion, which is very important in these cases. Our treatment does not end at the removal of mass. We need to know what the prognosis of the case is, and in case of any further management in the form of chemo or radiotherapy will be required. L, that stands for leaving a 4 mm margin in lid masses and removing the mass in toto in case of orbital masses. Now this is important because if you do an incision biopsy instead of an excision biopsy, the chances of recurrence become high, firstly, and secondly, the chances that the patient may need radiotherapy or chemotherapy in future also increase. So we are reducing the prognosis of the case in general. And lastly, fast action. These are cancers that we are dealing with. So if we diagnose them early, we actually help in preserving the functionality of the eye and the eyelid. This helps us in providing them better cosmesis post-treatment because we do not have to salvage a lot of tissue. And lastly, it improves the prognosis of the case. So it is the quality of the life and the life expectancy of the patient that increases. So in the end, what I would like to say is the important thing to do is diagnose them early. That's all from my side today. Thank you so much for your patient listening.
Yeah, thank you, Gunjan. It's good that you stick to time. And it was really a teaching lecture. I would say
I'd like to ask one question.
Yeah, sure.
When you do an excision, you do the histopathology of the cut edges to see the
Yes, yes. So
malignancy free.
Yeah. So for I'll do histopathology also, and in some cases where the spread is a lot, like in sebaceous gland carcinomas or basal cell carcinomas, where the margins are not well defined, then a frozen section of the margins. So otherwise, for all cases, clear margins to be there on all 4 sides and the base also. That I do in all the cases to see them.
Because in the lid we can't take a 4 mm. Can we take?
Yes, ma'am. So in the lid case, which I had shown, I've taken a 4 mm margin. For orbital cases, we have to remove it totally with the capsule. For all the lid cases, we can. We generally can remove it with the margins. So that's what I do. So pentagonal wedge resection was done in the case which I saw.
We have an expert panel also. Anybody from the expert panel want to say? Dr. Patil, please, if you want to say something.
Come to the mic. Come to the mic.
Or you can take a chair and come here. Yes. May I, in between, the next speaker should be ready for his presentation.
Thank you, Dr. Gunjan. And whenever there is doubt, definitely do biopsy. Second is at the primary level, if you are in doubt, do the CT scan and the other blood investigations. And never leave the patient without doing anything. Just putting lubricant or something like that. Rather, you keep following very closely because all these tumors are very dangerous. May cause many other problems, and the patient may lose the eye as well as morbidity for the life as well. Thank you very much. Excellent.
Calazion, which is notorious one. Calazion in the middle age group is always notorious. It can present like anything, and if you try to remove it, there is always a problem later on, recurrence, or may turn out to be sebaceous gland carcinoma. Yeah.